Good evening, all the students present here. We'll be starting with our session.
Good
So, the
evening.
topic for today is cardiovascular, and the speaker that we have here is Dr. Varun Pushkarna, sir. He's a senior consultant at internal medicine at Fortis Escortis Hospital, Amritsar. Some more aspirants will be also joining us. Thank you. Aspirants, this
Yes,
is
sir.
going to be an interactive session. You can also unmute your mic or you can also write in the chat box. Thank you.
So this is going to be interactive. What you see on the screen is a basic scheme how to go for assessing a patient who has been given to you on the cardiovascular station. So there are a few fundamentals that you have to understand. That is that you should not be vague in your examination. It has to be very, very structured. As long as it is structured, then you will never miss any step which is important vitally. Examiner will be impressed. That is the sole reason why you are going there for an exam, because you want to impress the examiner that I am fit to be given or qualified for MRC. So you develop a scheme of doing it and rehearse it again and again and again, so that it looks like and becomes a second nature of yours. It has to be very structured. My mantra to start cardiovascular examination is starting from the hands and ending at the feet. Okay. So whenever you reach and go closer to the patient which you have been assigned for a cardiovascular station, just look around. Look around. What is there? For example, when I had my cardiovascular stationing patient, the patient was lying in slightly 45-degree up position. The patient was on oxygen. The patient was, having crutches by the bedside, and there was an IV cannula on the patient. So I had a very, very brief, visual inspection that the patient is likely in heart failure. Like in other examination, they will prefer keeping fit patients, but in MRCP, you can get as sick patient as you can, and the fitter patients also. So first is just wash your hands, make it a habit that you wash your hands. Introduce, I am Dr. Varun Pushkarna and I have been assigned to examine your cardiovascular system. Is it okay for you? Take permission, take consent, and look around. You can see oxygen, you can sometimes see digoxin, a strip of digoxin tablets lying by the bedside, or you can see an IABP by the bedside. You can, see these things like a furosemide infusion by the bedside. So you have a fair amount of idea what you are going to deal with. Then look for the general appearance. Is the patient, like I'm telling you, my patient was 60-degree head and up position. I could make out that the patient might be in failure because the patient was on oxygen and the patient was tachypneic. So you have to look for any cyanosis and distress just by going there, and be very careful. These patients, if they have an IV cannula on them, to touch them with utmost care and respect that the cannula doesn't hurt, because these patients are already on cannula and sometimes thrombophlebitis is there. So the moment you hold their hands, even for a pulse examination, they might wince with pain. If they do, ask for forgiveness. Say, I'm sorry, I did not intend to hurt you, but if it has hurt you, I'm sorry. I'll prefer doing it in a calmer way. Please, I'm sorry. Look for the scars. These cardiovascular patients may have CABG, and all scars in the midline, they do not necessarily mean that the patient has had a CABG. It only means that the patient has an open heart surgery, which could be CABG, which could be a valve replacement, which could be in older times ASD, VSD closure, which could be a TOF or any congenital heart disease repair. surgeries. So you need to know that every scar is not a CABG scar. I mean, every mid-sternotomy scar is not a CABG scar. You should keep everything in mind. One patient I had in real life, one patient I had a mid-sternotomy scar, and I generally thought that the patient was young. He was just what, 34 years. He was a doctor. So I asked him, "Were you taken up for CABG?" So he says, "No. I met with a car accident, and in that car accident, few ribs they broke and they entered into my mediastinum and they caused a concealed cardiac rupture. So I was operated upon and my ventricle was sutured. That was, fortunately for him, it was the right ventricle." So imagine if we just look at a sternotomy scar and somebody, we assume that the patient might have had a CABG. So don't commit to that. Tell to the examiner that there is a mid-sternotomy scar. It is for the examiner to ask you, what does it signify? You just have to say that the patient has had a history. It looks like that the patient has had a open heart surgery. That could have been for bypass grafting. That could have been for a valvular repair or replacement. That could have been for, sometimes it is just for pericardiectomy. So these are the surgeries which can be accessed by opening up the sternum. Is that clear? Is that clear?
Yes, sir.
Great. So, as I told you, that my personal scheme of assessing the patient starts from the hand. I will try to draw a picture here. So, if the patient is lying on the bedside and you see the patient from this end, so
एक बार बोल के रखा है उसको, अभी बोलने के बाद में नहीं करना है, like
okay, if the patient is like this, so you start with the hands. You hold the hands gently in your hands and examine for any clubbing, examine for any peripheral cyanosis, examine for any splinter hemorrhages, examine for any palmar erythema, examine for any clubbing, examine for any needle prick marks, because sugar, some patients are diabetic, so sugar testing marks. So you look at them and then you turn the patient's dorsal side and see for any IV drip or any marks there. And then you go to the wrist. In the wrist, you check for number 1, radial pulse. And the moment you check radial pulse, always check on both sides together. So radial comparison. Always do. So you're still at the hand, okay? So check for any radial delay or any needle marks that will tell you about ABGs being taken, okay? Then you move up and go here. Sometimes you can even see a radial harvest. What is a radial harvest? Anyone? What is a radial harvest?
So for dialysis, they use.
So that is a AV fistula formation. That is not a radial harvest. So radial harvest is seen in patients who are taken up for young CABG patients. So what happens is they take a radial artery to be put on, because if you have any idea about CABG, I will just draw a diagram for your convenience. So this is heart, this is aorta. So when they put in new coronaries, the Lima to LAD graft is taken. Lima is left internal memory artery. So Lima is grafted always on the LAD territory. Okay. But what about the RCA and the circumflex? usually they are put like a venous graft. But in young people, good surgeons, they try to take a radial graft. So they put in a radial graft. So that is a radial harvest. You harvest the radial artery from here, and then you put it one end into the aorta and other end into the RCA or circumflex. Is that clear? Radial harvest. So alongside, you of course can check for AV fistula. You rightly said that. And here you check for the water hammer pulse. Water hammer pulse. Water hammer pulse is that you place one hand of your, so you place one hand here and one hand here. So basically you lift the arm upwards, and with the hand that is present here, you feel for the tapping of the pulses. Like this is the hand and you lifted it. So what will happen is you block the radial here and you just keep a soft hand here at the elbow. The pressure will come down, and if it completely comes down, that it becomes a water hammer pulse. In which condition do you see water hammer pulse? So you see that in aortic regurgitation. Okay. So once you move from the fingers to wrist to elbow, then you move right to the neck, directly to the neck. Of course, you can palpate for axillary, or you can check blood pressure here on the forearm. But usually you are not required to check the blood pressure. You can tell it later that I would also want to check for the blood pressure and pulse oximetry of this patient. Okay. All right. So here you check for two things. One is visibly see for any carotid pulsations in the neck, and also look for any JVP. Now, if the JVP has to be checked at 45 degrees angle, and also once you see the JVP, the study is not complete until you press on the liver. So that is called hepatojugular reflux. So always ask if the patient has any pain in the abdomen. If it is there, tell them that I'm going to press on your abdomen. Please bear with me. And if there is pain, let me know so that I can stop my examination. So you press on the abdomen and you see for the JVP to rise. That is a positive hepatojugular reflux. What is the significance? It can diagnose occult heart failure patients who are diurized and not in obvious heart failure. But when you press upon the liver, the JVP goes up. That can tell you about the this thing, about the
Heart failure.
heart failure. Okay. Then from jugular, you go up to the lips. So in the lips and in the eyes. So you look for any pallor, you look for any jaundice, you look for any telangiectasia on the face. In which condition do you see telangiectasia on the face? Scleroderma. Okay, scleroderma, because these patients can also be there in the cardiovascular station because of resistant hypertension, because of scleroderma can produce hypertension. Okay, so and you see the oral cavity for central cyanosis. Okay, from here now you come down and look at the chest. In the chest, you look for any, in thin people, you look for any apex beat. If you can't see, turn the patient towards yourself and try to focus if you can see an apex beat. So you've seen the apex beat, or if you've not seen the apex beat, but just look at any mid-sternotomy scar, any lateral scar. If the, let me erase this photo.